This podcast is supported by Zoll LifeVest. Sudden cardiac death is a leading cause of mortality in low EF patients with heart failure or following a heart attack. Zoll is proud to partner with your care team to pursue better outcomes together. Visit lifevestresults.com to learn more.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated CardioNerds everywhere are working hard to fight this global epidemic. These are their stories.
Hello, Team CardioNerds. Dan Ambinder here. I could not be more excited to share this amazing CardioNerds Rounds recording. What is CardioNerds Rounds, you ask? Well, CardioNerds Rounds are virtual rounds with world experts where we get to learn the latest evidence through challenging cases. This incredible series is co-chaired by master educators Dr. Karan Desai from the University of Maryland and Dr. Natalie Stokes from UPMC. CardioNerds Rounds are generally held once monthly during the noon hour Eastern Standard Time, but then are released via podcast like in this episode for your asynchronous medical education pleasure. You can find out more about CardioNerds Rounds and register for upcoming events on cardionerdsrounds.com/rounds. This episode features challenging cases that highlight modern guideline-directed therapy in heart failure with Dr. Randall Starling. Now, of note, this CardioNerds Rounds was recorded prior to the release of the 2022 AHA, ACC, HFSA heart failure guidelines, but the tenets that we learn here remain extremely pertinent. CardioNerds is an independent, fellow-founded platform with the mission to democratize cardiovascular education. To continue creating free and unbiased quality content, we are proud to collaborate with all stakeholders, including trainees, experts, fellowship programs, professional societies, industry, and patient advocacy groups. This episode is supported with unrestricted funding from Zoll LifeVest. A huge thank you to Mitzy, Applegate, and Yvonne Chevere for their top-notch production skills that make CardioNerds Rounds such an amazing success. Of course, the curriculum and content is planned, produced, and reviewed solely by CardioNerds without external bias. Case details are altered to protect patient health information. And with that, let's round. Karan, take it away.
I want to welcome all of you to CardioNerds Rounds. My name is Karan Desai, and I am editor of the CardioNerds Academy. So CardioNerds Rounds, the goal of these sessions is to bring together learners from all levels, all across the world, to go through real-life cases and learn from world experts. And we truly have a world expert here with us today. And mainly, we want to learn their approach to specific cases that we all see in practice and see how they incorporate the latest evidence into their cases. With that, I'll turn it over to Natalie Stokes.
Welcome, everyone. Thanks so much for joining us. My name's Natalie. I work with Dr. Desai to learn from the experts. We're thrilled today to have our CardioNerds co-host, Dr. Tiffany Dong. She is a second-year chief fellow at Cleveland Clinic. She'll be guiding us through rounds today. So, Tiffany, take it away.
Thank you so much, Natalie. I have the pleasure of introducing Dr. Starling, who's going to be our expert discussant today. Dr. Starling is luckily at my home institution, Cleveland Clinic, and he's been here for a while now. He currently is on the editorial board of the Journal of Cardiac Failure, and he has been on the editorial boards of Jack Heart Failure, and the Heart Failure Review Board as well. He was past HFSA president from 2018 to 2019, and he was head of our heart failure and transplant section from 2003 to 2016. I think most importantly, from a fellow standpoint, he's one of our favorite attendings to work with. He always goes very quickly in our clinic draft when he's available, and we really enjoy learning from him. With that, we're going to start rounding then. We're going to see about 2 to 3 patients today. I do want to thank my co-fellow, Dr. Trey Martin, for this first case. He's laid the groundwork for the structure of how we manage these patients. Case 1, we're seeing this patient. He's a 63-year-old male in heart failure clinic. He has a known non-ischemic cardiomyopathy with an EF of 30%, and he is presenting with worsening shortness of breath that's progressive over 6 months. First notable when lifting boxes at work, and now he can't climb 1 to 2 flights of stairs without getting short of breath. He's actually due for an ICD as primary prevention. With the symptoms, the plan was to get a right heart catheterization to optimize him prior to getting his ICD. In terms of past medical history, he does have a mutation associated with dilated cardiomyopathy and a cardiac MRI from the year prior showing biventricular dilatation with a low ejection fraction. In addition, he has a history of AFib with 2 ablations and also sick sinus syndrome with a dual chamber pacemaker in place. His family history is notable for a brother who passed away suddenly and a niece with HOCM. His social history is non-contributory. He's retired and doesn't use any substances. These are his current medications in clinic. His GDMT regimen includes metoprolol succinate, apelrenone, and lisinopril. He's also on a daily dose of furosemide and dofetilide and warfarin for his AFib, as well as a statin. He's ready for a right heart catheterization. These are the labs that we draw in PrEP. I'll turn your attention to his potassium, which is slightly elevated at 5.3, and a creatinine of 1.08, which is his baseline. His CBC is unremarkable. His NT-proBNP is elevated for him at 1700. These are the echo images we have from right before. So his EF is moderately decreased with mildly dilated left atrium. And then he does have a little bit of PR around the pacemaker lead on the right image, but nothing else significant on this. And then for the moment of truth that we've all been waiting for, so this is his right heart catheterization done through his right IJ, and I included his vitals here for our understanding. So he has a right atrial pressure of 15, a RV of 52/16, PA pressure of 59/32 with a mean of 41, and an elevated wedge pressure of 28 with notable V waves of 40. His cardiac output and index by thermo are 4.1 and 1.8 respectively, and his cardiac output and cardiac index by SIC are 2.8 and 1.2 respectively. We also noted his TPG of 13, his TVR of 3 Woods unit, DPG of 4, and his SVR, which is elevated at 1,990. So you can see that he has biventricular filling pressures that are elevated, including his wedge, and he has reduced cardiac index both by thermo and SIC. So our first question for Dr. Starling is, what would you do next? We've stopped the diltiazem, I think we can all agree, but our options are discharge the patient home with a higher dose of oral diuretic, admit the patient for IV diuresis and hold his beta blocker, admit the patient for diuresis and start an SGL2 inhibitor and ARNI immediately, admit the patient for milrinone initiation and hold his beta blocker, or admit the patient for uptitration of oral GDMT and IV diuresis. The last option is a totally different direction.
Tiffany, I have a question. What was this patient's NYHA class and symptom status when he walked in for this?
So his NYH class had progressed over the past 6 months to about class 3. And prior to this, he had not had any hospitalization, was a pretty functional guy otherwise, but did note this marked decline.
So the majority answer is to admit this patient for uptitration of oral SGL2 and ARNI immediately. I think those questions were similar answers, but mainly focusing on those 2 medications. So why don't we turn it over to Dr. Starling to hear how he would approach this case?
Thank you. You know, I think the way a patient is managed is going to vary depending on where they are. And we're at the Cleveland Clinic, so I'm going to give you what usually happens at the Cleveland Clinic, which may not happen that way at other facilities. And the first comment I'd like to make is the whole issue of why did this patient even get a right heart cath to begin with? And I'm going to assume that pre-ICD, someone decided that they wanted to make sure that this patient was quote unquote optimized. And number 2, as a sidebar, you could make the argument, well, this patient has a long-standing history, but in general, when you're looking at an ICD or a CRT, one of the questions we get asked all the time as a heart failure specialist is, has the patient been optimized? And I think everyone would recognize that this patient has room for improvement, so to speak. The other thing that I kind of do routinely with any heart failure patient, whether they're an inpatient or an outpatient, is I kind of run a mental checklist to help me risk stratify the patient. So this patient has a sodium of 142, normal, a BUN and creatinine that are unremarkable. So right off the bat, if you reflect on the ADHERE registry, which is inpatient acute decompensated heart failure, you can begin to risk stratify it. And the ADHERE registry gives you very simple data points to give you an estimate of inpatient mortality. But from many regards, this patient was quote unquote low risk. Now the BNP was 1700, which is certainly not sky high, but in general, we like to see BNPs under 1,000 based on what we know from GUIDE-HF and other studies. So here's a patient at the Cleveland Clinic in the cath lab. Somebody rings up the attending cardiologist and says, hey, the wedge is high, the index is low. Boom, they get admitted. That's what happens at the Cleveland Clinic. So once the patient comes in, then what happens next really is a function of the trajectory of the hemodynamics. And again, at our institution, the Cleveland Clinic, more often than not, a patient will get treated like this with sodium nitroprusside and IV diuretics. We're very biased toward a vasodilator regimen and not using an inotrope. So one of the choices was milrinone, which I don't think anybody opted for that. And that's the right answer. That's a good answer. And there was actually a clinical trial that was done called Optine HF a while back, published in JAMA. The PI was from Duke. Michael Cuff was his name, Cuffe. And basically the milrinone empirically for an acute admission to the hospital failed. Patients had more AFib, et cetera. Once that happened, the inpatient use of inotropes pretty much disappeared on the horizon. So once this patient comes in the hospital, the other pet peeve of mine that any fellow that's ever rounded with me knows is that it seems that oftentimes there's a low threshold to stop beta blockers. And I'm not sure where this culture came from, but I think what is important to recognize is that 30 years ago, we didn't use beta blockers. So they're relatively new. And when carvedilol first came along, someone well known to CardioNerds, Dr. Brenwald, was writing the protocols. And so there was a protocol that said, what do you do with carvedilol when a patient's admitted to the hospital? And it said, if the patient is decompensated, cut the dose by 50%. Don't ever stop the beta blocker cold turkey. There's this concept of beta blocker withdrawal, which is usually not an issue if the patient's on another neurohormonal antagonist, but it's theoretical. So I think most of the time, well, if a patient's in cardiogenic shock, then you get rid of the beta blocker. But for the routine patient that's admitted, you either leave the beta blocker where it is or you cut the dose while you're optimizing the patient. This patient was on, I believe, 50 milligrams twice a day of metoprolol succinate. And the target dose of metoprolol succinate from the MERIT HF trial, the mean dose was 154 milligrams a day. So most algorithms will say that drugs target dose is between 150 and 200. So at the Cleveland Clinic, patient would be admitted. They'd have the PA catheter in place. This patient has a ton of blood pressure. I think we saw 155 on the systolic. Almost unquestionably, they'd get put on nitroprusside. And I'm sure there would be an active discussion about conversion from lisinopril to ARNI, which would be appropriate. And of course, everyone knows you need to factor in the 36-hour washout when you go from an ACE to ARNI. Then the only other comment has to do with this patient's mutation. So this is a mutation seen commonly in hypertrophic cardiomyopathy, 30% of the patients. We weren't told anything about an outflow track gradient, or what have you. And it is true that certainly some patients with HCM, and there are many variants, are non-obstructive, and some patients start off with relatively preserved systolic function that deteriorates over time. Strong family history of AFib. So that all sounds pretty believable to me. And for this patient, of course, very important that family members are screened for this mutation as well.
Thanks, Dr. Starling. We will turn it back to Tiffany to go through the initial course here for the patient.
Tiffany, I didn't mention, but it was on the slide that diltiazem was stopped. It's quite curious to me why this patient was even on diltiazem, whether somebody did that for AFib rate control or this patient had obstruction at some time, what that was all about. But obviously that drug had to go away.
Yeah, I believe digging in the chart, it was initially started for AFib control, and then I think it was kept on because he was doing relatively well until he saw us in clinic. I will say that they did hold his lisinopril a few days prior to this right heart cath. So on day 1, he is admitted to our heart failure ICU with the swan still in place. And then the first column is his mean arterial pressure of 127, and then the elevated biventricular filling pressures, as we mentioned. Here, they start him on hydralazine 25 3 times a day, eplerenone 25 daily, and then they diurese him with furosemide IV. They continue his metoprolol succinate at 50 twice a day. And then day 2, you can see his filling pressures are improving with an improved cardiac index. And we did start him on sodium nitroprusside that we quickly up titrated to 200 mic a minute. And we are able to start him on a low dose of ARNI, 24 to 26 milligrams twice a day. They increased his hydralazine to 50 3 times a day. And then on day 3, as you can see, his filling pressures continue to improve with a preserved cardiac index of 2.6. And he's weaned off his sodium nitroprusside. He's up titrated to mid-dose ARNI, 49 and 51 twice a day. In addition, and he's kept on his eplerenone, hydralazine, and metoprolol. And then day 4, very similar numbers, and he actually gets his swan removed and is transferred out to our heart failure floor. On day 5, they did stop the hydralazine and they up titrated his eplerenone to 50 milligrams a day. And then day 6, he is on full dose of ARNI, 97 to 103 milligrams twice a day. So we stopped the diltiazem, we stopped the lisinopril, we started him on ARNI high dose twice a day, and he's on eplerenone 50 milligrams, so doubled. And then we continued the rest of his medication.
So 2 questions with that is, when do we consider using metoprolol succinate BID rather than daily? And is there any reason you would switch someone from Toprol to Coreg on admission?
Thank you, Natalie, for those questions, which are very, very common questions. Probably the best answer I can give you is this is dealer's choice. It's the style question. I don't know that there's a tremendous amount of data to guide one. You know, most people like to opine that carvedilol is a more effective, quote unquote, antihypertensive because of its alpha effects. And I think in head-to-head comparisons, you can probably substantiate that with some evidence. And I think very commonly, I see amongst my partners, individuals backing away from carvedilol if they're worried about the patient's blood pressure. So in this particular patient's case, depending on his blood pressure, you may or may not have had a bias to use carvedilol over metoprolol. There was also a question asked regarding the dosing. So yes, metoprolol succinate is a once-a-day drug. Having said that, I think certainly in the setting of AFib and rate control, I have used that drug as frequently as 3 to 4 times at doses. Please don't do this, but I've had patients on up to 200 milligrams 3 or 4 times a day, metoprolol succinate in the setting of atrial fibrillation. I can't give you a number, but my guess is that somewhere between 25 and 40% of heart failure patients may wind up on metoprolol succinate BID. And I think the gauge for that is probably twofold. One, watching the heart rate trends. And number two, sometimes patients will say to you, gee, 100 milligrams of metoprolol, it's hitting me like a sledgehammer. I can't take it. And you can either reduce the dose or you can reduce the dose and increase the frequency so that you get the same total daily dose of a beta blocker. So some patients will tell you they tolerate it better, BID. So that's as much as I can tell you about it. The beta blocker, other than to say, is one better than the other? Personally, I don't think so. There was a study done, I believe, by Milton Packer many years ago. The only caveat was it wasn't metoprolol succinate, it was metoprolol tartrate compared to carvedilol. And that was a criticism of the study, which opined in favor of carvedilol. But I think they're interchangeable. And as far as bisoprolol is concerned, I plead ignorance. I have almost no experience with that drug.
This patient obviously gave us the gift of having a lot of afterload available for us to work with. But in those patients who have reduced blood pressures, how do you typically titrate the medication? Do you go by MAP versus systolics? And is there a particular blood pressure cutoff you use for the RE dosing? And this feeds into the question of how quickly you feel comfortable adjusting that dosing.
So just to give you 30 seconds of background to understand where I'm coming from. So I was a national country leader for Paradigm HF, so I've been around the drug for a long time. Number two, I was involved with the LIFE study where we used sacubitril valsartan in very severe heart failure. And I'm currently on the steering committee for Paraglide HF, which is basically the pioneer type study to use this drug in the hospital. So I'm quite comfortable with using the drug. I don't use the mean arterial pressure. I tend to use the systolic pressure. I generally will like a systolic pressure over 100. I've started many patients on sacubitril valsartan with blood pressures as low as 90, probably exceedingly rarely in the 80s. When I'm nervous about a patient and their tolerance, what I will usually do is give them valsartan just to test the water to see how they tolerate the valsartan. And I'll usually give valsartan at 20 to 40 milligrams. If they tank their pressure on one dose of valsartan, I'm done. I don't even try it. If they tolerate the valsartan, I will move ahead with the sacubitril valsartan. The other thing that I do, which is off-label, and I can't endorse it because you are not supposed to a tablet in half, because in theory, you're never going to get a 50-50 split. You could get a 40-60 or whatever. Having said that, I have patients take a half dose of 24-26. I just saw a patient in my clinic yesterday who's been on that dose for over a year with a blood pressure of 93 systolic, who brought her EF up from 25 to 50 on Entresto and carvedilol, but she only tolerates a very low dose. There's quite a bit of data that would suggest that there's a gradient between the dose and the efficacy if you look at outcomes. But having said that, you're doing your patient a favor, even if they only tolerate a low dose. So that's basically the strategy that I take.
Thank you, Dr. Starling. I think that was full of a lot of pearls, including the use of sodium nitroprusside, how you titrate sac-val or sacubitril valsartan, and many other pearls, including the utilization of metoprolol in the hospital and not dose reducing.
Just remember, there are blood pressure guidelines as far as starting from the package insert in Novartis on starting 24, 26, or 49, 51. So if I see a patient on 20 BID of lisinopril, I'm probably going to start out at 49, 51 and not at the lowest dose. And how fast can you titrate it? Well, as an inpatient and the patient is right there and being monitored, I would say quickly. Probably if you give 2 or 3 doses and you feel there's blood pressure, I don't think you're going to harm the patient to up titrate.
Thanks, Dr. Starling. I think, Tiffany, you have another patient for us to round with Dr. Starling. So I will turn it back to you to tell us about this next patient.
Thank you. We're back in clinic again, and we're actually going to see Mr. HW. And I want to say a special thank you to Dr. Bhattacharya, one of our heart failure attendings, for this really interesting case. I will frame it by saying that he's had a long, extensive history that we'll get through. We'll be remiss if we didn't mention his history, but the question really comes at the end. This is a 43-year-old male. He has a familial dilated cardiomyopathy associated with a TTN mutation, and he has a heart wear that was placed in February of 2018. He presents to clinic with low flow alarms. He's feeling pretty well despite these alarms, denies any dizziness, syncope, no lower extremity edema or orthopnea. He does have chronic dyspnea on strenuous exertion, but this is stable from baseline. And he's had no episodes of bleeding and has not had any fevers or driveline issues. Diving into his heart wear history, he received his heart wear actually as his index admission when he presented with SCAI stage D cardiogenic shock that required an Impella 5.5 and dopamine. His EF at that time was noted to be 15% with a dilated left ventricle of 5.9 centimeters. And he had moderately reduced RV function, and he underwent a heart wear at this time as destination therapy because in his past medical history at the time, he did have an alcohol use disorder. Now it's in remission. He did have one hospitalization since his index admission for a GI bleed in 2019 with an EGD and colonoscopy that was unrevealing. In addition, he had paroxysmal atrial fibrillation. These are his current medications. So his GDMT includes carvedilol 12.5 twice a day, lisinopril 20 daily, spironolactone 25 daily. He's also on digoxin and torsemide as needed, in addition to magnesium and potassium supplementations and warfarin for his paroxysmal AFib as well as his heart wear. That fight actually looks pretty good. We do note the low flow alarms when interrogated, but otherwise his exam is unremarkable. So this is his current echo, not his index admission, but his current one. As you can see, his LV is pretty robust. His EF was judged to be about 55%. His RV is somewhat dilated, but contracting well, at least on the peristernal long and short shots that we have. And there were no significant valvular abnormalities noted on subsequent images. So he does undergo a CT of the chest to look at why he may have these low flows. And the CT was notable for a fluid pocket essentially within the driveline site from the proximal segment. I think at most they measured at 10 millimeters at the proximal end aspect of the conduit. They didn't note any gas. And then I have a still shot on the right kind of show that he did have this fluid collection. So they were considering a VAD exchange for him. However, with the echo showing LV recovery and invasive hemodynamics in the OR and a ramp study that corroborated his return of left ventricular function, his VAD was actually decommissioned at that time. And in the OR, they did note an outflow graft occlusion with the fluid collection, as we stated previously. So after his VAD is decommissioned, they try to start him on a low dose of ARNI, but he's unable to tolerate it due to hypotension. So they settle on discharging him on lisinopril 5 milligrams. They reduced his carvedilol from 12.5 to 3.25 twice a day, and his spironolactone, torsemide, and digoxin were stopped. In clinic, he's noted to have NYHA class 2 symptoms, and his creatinine and his potassium are both at baseline. Creatinine was 1.1 and potassium was 4.3. Our question for Dr. Starling, and the poll question is, what would you do at his subsequent clinic visit? given that he has EF recovery, his VAD is now decommissioned. The first option is do not change his goal-directed medical therapy. Second option is to increase his beta blocker and ACE inhibitor at the same time. Third is to add spironolactone before touching his beta blocker or ACE inhibitor. Fourth option is adding an SGLT2 inhibitor before other medication changes. And the fifth option is to increase the ACE alone at first and then try to transition to ARNI again. And the sixth option is none of the above. You would do something different.
Thanks, Tiffany, for the case presentation. Theodora in the chat had asked what his current medications are. And Tiffany, I believe he's just on carvedilol and lisinopril currently from a guideline-directed medical therapy standpoint. Is that correct?
That's correct. He's on low doses of both. So he's on carvedilol 3.125 twice a day and lisinopril 5 milligrams. The rest of it is the GDMT, including spironolactone, had to be stopped.
Dr. Starling, how would you approach this patient if he came to your clinic?
Thank you. So a couple comments before we get into that. So first, I want to point out that in the case presentation, it was noted the patient had a palpable pulse. So anytime you see an LVAD patient with a pulse, that should cause you to investigate, so to speak. Just remember when Dick Cheney had an LVAD, people said he was pulseless, and that's because he had no heart. But for the usual LVAD patient that loses their pulse, you've got to think about how much is the native heart contributing. And take your stethoscope, and if you hear normal heart sounds before you even do an echo, you can be sure the aortic valve is opening and closing. So I just wanted to mention that. And number two, low flow alarms. There's 3 or 4 things that you think about. You think about volume, you think about the right ventricle, you think about cannula issues, and you think about tamponade. So what was found in this particular case. So the decision was made to decommission the LVAD, which has its pluses and minuses, but that was the decision. You do need to put an occluder. Well, if the patient was in the operating room, they tie it off. Sometimes percutaneously, we put Amplatz occluders in the outflow graft to prevent retrograde flow. Probably wasn't an issue for this patient. So now the discussion is myocardial recovery in the setting of an LVAD. So what is the evidence that we have? Not a lot. And this occurs at least in large registries under 5% of the time. It's most common in a woman with non-ischemic cardiomyopathy of relatively short duration. And last year in October in Circulation, Cleveland Clinic was part of a study called Restage HF, which basically took patients like this, put them on medical therapy, and went through a specific protocol for recovery. So that recovery protocol included a beta blocker, specifically an angiotensin receptor blocker, not an ACE inhibitor, and it included a MRA. And the beta blocker that was preferentially used was selective beta blocker, metoprolol. I personally am a believer in optimizing GDMT after an LVAD is put in and looking for recovery. If recovery occurs, what comes next? Optimization. In this patient, I would clearly think about adding an MRA. I would be thinking about getting the patient on sacubitril valsartan, even though we don't have a lot of data on that. We think that's the best RAS inhibitor that we have based on non-LVAD data. And I was intrigued that number 2 on the poll was SGLT2 inhibitors. That would be down the line for me because I'm still waiting to see any data that emerges on reverse remodeling effects of SGLT2 inhibitors. I've seen a couple abstracts with some signals coming in, but the main drugs that can facilitate reverse remodeling are beta blockers and sacubitril valsartan. So Januzzi published a paper, I believe in JAMA or JAMA Cardiology. It was not a randomized trial, but it showed a mean increase in ejection fraction of about 9%. So the best long-term drugs for this patient, in my mind, will be sacubitril valsartan, a beta blocker, and an MRA for sure. And in this particular setting, these medications are for the rest of the patient's life with their existing heart. We don't stop the medicines at any point in the future. You're probably familiar with the TREAD-HF study that was done and published in Lancet that looked at non-ischemic cardiomyopathy and recovery, randomized patients to withdrawal. And at 6 months, about 40% of the patients had decline in ejection fraction. So the word that most follow is you never take the medicines away. Last comment has to durability after recovery in an LVAD setting. And that is, in my mind, an unknown. There's going to be some follow-up data presented and published from the Restage HF study, but our experience at the Cleveland Clinic has been mixed. We've certainly had some patients that had recovery that we explained at the LVAD that within weeks or a month or two, their heart failure syndrome returned, and some wound back up on LVADs again, or ECMO, etc. I have one patient in my clinic like this that's at her 5th year that was on an LVAD. She was explanted. She got sick. She was on ECMO, listed for transplant. We were able to salvage her and get her through it. And she's 5 years out now on GDMT with a stable EF of 40%. I don't see it often, but we should always strive for it.
Thanks, Dr. Starling. That was wonderful insight for everyone that's listening here. Tiffany, do you want to go through what happened next?
So at the first month, you can see his blood pressures all luckily remain above with a systolic above 90. First month, like we mentioned, he has NYH class 2 symptoms that essentially persist through his clinic visits. So they increased his carvedilol to 6.25 twice a day and continue his lisinopril. And about 1.5 months later, they continue to increase his beta blocker to 12.5 twice a day and continue his lisinopril. And then 2.5 months later, they're able to start him on spironolactone and keep him on his beta blocker and ACE inhibitor. And then at 6 months, they start to increase his lisinopril to 10 milligrams a day. And then 7 months, what I found very interesting is this was all done by our pharmacist over the phone and the patient coordination. They actually switched him with a 3-day washout of his lisinopril to low-dose ARNI, and they up-titrated him to medium dose after 3 days, which he tolerated quite well. They continued his beta blocker and his MRA. And then at 10 months, they got him to a gold dose of carvedilol 25 milligrams, and he's on mid-dose ARNI as well as 25 of spironolactone.
Thank you, Tiffany. Dr. Starling, this patient was titrated up, just as you had mentioned before. We had actually seen the course here on his ARNI, spironolactone, as well as the beta blocker. I have a question, not necessarily just for LVAD patients, but patients in general with heart failure recovered EF. Does the type of mutation matter to you or influence if the patient does have a genetic mutation, which, if you will, titrate down medications or titrate up because of risk of whether it's sudden cardiac death with that mutation or risk of recurrence of heart failure? I believe this patient had a Titin mutation.
Good question. And so if a patient has a mutation, whether it's known or a VUS, it bothers me. It does not affect how I deploy GDMT. And just in a recent issue of JACC, there was a study out of Spain looking at mutations and dilated cardiomyopathy, showing worse outcomes in, I think, 60% of patients that had a known mutation or a VUS. I worry that a patient with a familial genetic type cardiomyopathy is going to do worse, but that's just my own problem, so to speak. but I just deploy GDMT as I normally would. The only exception being in some cases, depending on what the diagnosis is and what the mutation is, there may be specific scenarios where an ICD would be indicated independent, being below the typical EF threshold. But no, this mutation would not have affected my treatment of this particular patient.
Thanks, Dr. Starling. We have a question from Devesh Ray, who's also one of our CardioNerds Academy fellows. And his specific question was, in patients that have had a decommission in VAD, do they still need to be on warfarin?
Yeah, don't forget there's a cannula that's left behind in the left ventricle. So I personally would keep the patient on anticoagulation. And I imagine that there would be multiple different opinions on that. But having a piece of metal in my left ventricle, I'd want to be anticoagulated.
A couple other questions came in, and both of these questions are related to how to titrate in the outpatient setting. And so are there any factors that specifically influence how quickly you add guideline-directed therapy? And in patients with recovered EF, have you used any PA pressure monitoring systems, such as the CardioMEMS device, to guide whether you'll titrate guideline-directed therapy?
Yeah, most of the time we're titrating when we think we're treating half-ref, so to speak. So this particular patient's a little unusual in that the patient was on GDMT, LVAD was decommissioned, and then there was this incentive to optimize the GDMT. There's a lot of chatter about this now. I don't think you need to worry too much about the ejection fraction because most of the medicines that we use to affect the myocardium now, we don't have any restrictions based on ejection fraction. As far as CardioMEMS and titration, I think most of the time CardioMEMS revolves around high PA pressures, which is what they measure, and making a judgment regarding a diuretic versus a vasodilator. And if you look at the original study that was done for the approval of CardioMEMS, a lot of the titration was with vasodilator therapy. So I don't think I need CardioMEMS numbers most of the time to up-titrate a patient. I'm going to base that upon the physical exam and the vital signs, basically. And, you know, if you told me the patient's PA systolic was 28 and they walked into my office and their systolic pressure was 140, I'm probably going to up-titrate their sacubitril valsartan, independent of what that PA systolic pressure is.
Thanks, Dr. Starling. So Tiffany, you want to ask our final question?
Thank you. So I know you had mentioned TREAD-HF already and continuing GDMT in this recovered EF population. I've seen a few times as a fellow, people who come in for their first time of atrial fibrillation, their EF drops with the AFib, they get cardioverted, and then they restore normal sinus rhythm and their EF recovers. Would you still recommend for tachyarrhythmias that are reversible, continuing or titrating GDMT?
So great question. And talk to any of my former or current clinic fellows, Dr. Bott, Dr. El-Javine, Dr. Brooksbank. My clinic is loaded with patients with AFib and low EFs that have normal ejection fractions now. And part of the problem is it's the chicken or the egg discussion that what came first, AFib, then LV dysfunction or LV dysfunction, and then AFib. Most of the time, probably with few exceptions, I will continue GDMT in somebody that has a low ejection fraction, plus minus dilatation of their left ventricle, where we focused on the combination of GDMT and sinus rhythm. Once in a while, a patient will improve quite a bit, and the same argument or discussion applies to a patient with a left bundle that, with rare exception, and Wilfred Mullins actually published a paper about withdrawing GDMT in a subset of patients with left bundle and CRT that recovered their ejection fraction. I'm not overly enthusiastic about that concept myself, so I will tend to continue both in AFib as well as in left bundle branch block, even with full recovery.
Thank you so much.
I just want to thank Dr. Tiffany Dong for putting these cases together. It takes a lot of effort to go through these cases and present it in this format. And thank you especially to Dr. Starling for your insight, your expertise. Thank you again, everyone joining, and we will see you next time.